Record. We are recording. Okay, you ready?
Go for it.
Here we go. Hello, my name is Shannon Studden, and I am a Senior Program Specialist here with the National Rural Health Resource Center, and I'd like to welcome you to the Advanced Nursing Education Workforce, or a new webinar series on transitioning to practice. The series is offered by the National Rural Health Resource Center through an agreement with the College of St. Scholastica, and it's funded through the ANEW grant offered through the Bureau of Health Workforce within the Health Resources and Services Administration. The purpose of the series is to provide advanced practice nursing students and recent graduates from the College of St. Scholastica's Rural Academic Practice Partnership, ANEW program, with tools and strategies to help smooth your transition into practice. In this webinar, we'll share some strategies to help you plan for and manage challenging conversations with patients, families, and colleagues. We're going to do something a little bit different today. So instead of having a more formal, structured webinar with slides, we decided to make it a little bit more of a conversation. We're fortunate enough to have two experts here to share their knowledge with us, Sarah Carl and Mark Wida. I'll tell you a little bit about both of them, and then I will turn things over to them. We'll do sort of a Q&A format. So Sarah Carl has been practicing as a physician assistant in internal medicine for just under 10 years. She provides care to patients from 18 to over 100 years old. And she's also had many administrative positions, including coordinator for all APC students at Essentia Health and as section chair of the Superior Clinic. Mark Wida is a lifelong Duluthian. He completed his Master of Science in Nursing with an FNP-BC in 2015 from the College of St. Scholastica. Mark started at Essentia West Clinic in family practice and moved to St. Luke's Community Care in 2018. He works with short-term rehab patients, and he's also one of the primary care providers for residents of long-term care facilities and assisted living facilities. Something unique is that Mark has patients who are homebound and need a provider for chronic disease management, as well as acute needs that may be able to be treated at home rather than in the hospital. So thanks, Sarah and Mark, for being willing to share your knowledge with us today. And if it's okay with you, I'll just dive right in with the first question. So Sarah, let's start with you. So how we're talking about difficult conversations today. So how do you prepare for a difficult or a sensitive conversation?
So the one thing that I think is really important when I'm preparing for a difficult conversation is making sure I have all the information I need up front before I enter into that conversation. So if we're talking specifically with patients, if it's maybe a new diagnosis that's going to be, troublesome to them, I make sure that I have all the information about all of the imaging, the labs, everything, all of the supporting data with me when I go into that conversation. I plan for the questions that are going to come up, whether it's from the patient or from the family or really whoever I'm talking to. I try to anticipate those questions so that I can then plan for my response and how I'm going to handle those questions once they come up. And then the last thing that I really think is really important is making sure I have those next steps already either in place or planned out as much as possible, so that the patient and family then leave that conversation knowing what's next. Because I feel like when you're having these really difficult conversations, specifically with patients and families, it can be really overwhelming. And the last thing that you want them to really have to worry about is, okay, now what? So if you can have as much of that planned out in advance, I find that really helpful to them and really kind of reassuring that we are going to help take care of the situation.
Sounds like a lot of prep work, a lot of homework ahead of time before those. Thanks, Sarah. Mark, how about you? How do you prepare for a difficult or sensitive conversation?
Well, I think, as Sarah said, it's the pre-planning, it's the preparation. And then I think when you're in the room, you have to clear up maybe assumptions that we might have. We come in through the door with a certain thought process. And so I think, talking to the patient and finding out their understanding, maybe try to get from their perspective where they're at, so that you're basically approaching this from the same platform, so to speak. So I think engaging them to figure out where they're at with things, and then you can help better launch, so that there's not, a lot of times I think people can have misunderstandings, or they maybe don't have all the information. So it's kind of an opportunity to draw from the patient and or the family member where they're at, because we come in with a certain knowledge and expectation. So I think we have to prepare for it. We have to be thinking about that, as Sarah said, and it's just kind of before you jump, and obviously Sarah's probably doing this too, but it's like, you just got to figure out where the patient is and give them that time. And patients like to be heard. And I think when they're heard, no matter what comes out of that conversation, I think is like when they're part of that process, that really helps the difficult process as it is, and it can be. So
yeah, and that probably really affects the dynamic of the conversation when you're approaching it that way.
Yeah.
So Mark, how did you learn how to have these conversations? This isn't easy. We all have to learn a little bit. So how did you learn about it?
Right. Well, I mean, I think part of it is life, living life, and relationships and experience that we have from whatever course we're coming from, whether we were, an RN or some kind of other healthcare provider, or just life in general, relationships. I think that's key. Mentors for me, like having my colleagues around me, whether they're other APCs or they're doctors, asking them about like, how do you envision handling this? So I think, that's kind of the collegial part of practice. So, it's, I probably would say I get it from both sources, colleagues, mentors, which may be the same person or just living life.
Sarah, do you have similar sources for your learning?
Yeah, I think so. I think a lot of it is just trial by fire. It's just jumping into these conversations as a new provider and really kind of working out the kinks as you go. I don't think there's many programs that work at having these conversations besides maybe, a short little snippet. So I think it's awesome that you guys are putting together this for your students to draw on as a resource. I saw a little bit of difficult conversations when I was in my rotations, just because I did an oncology rotation and an ICU rotation. And so I saw some of those difficult conversations, which I thought was really helpful. A lot of my other, students that went to school with me didn't have that because those were elective rotations, but I think it's really not being afraid of it and just really trying to go for it, because you do kind of learn as you go.
Thanks, Sarah. So we said we're going to talk about conversations with patients, with families, with colleagues. Let's start with patients. So Sarah, what are some of the most common types of challenging conversations that you have with patients?
So I was really thinking about this question before we started this and coming up with a list of all of these tough conversations. And the one thing that I really found in common is when a patient comes in with an agenda and they're set in their agenda. This is kind of the common thread. So whether it's around chronic pain medications, they want opioids, they want stimulants, they want benzos, they maybe come in and they have a cold and they've had it for 3 days and they think they need an antibiotic, but they don't. And so I think those are oftentimes the most challenging conversations when the patient is Dr. Googled and they know what they need, or this is what they think is the best option for them. And then trying to steer that conversation in such a way that then we can use our medical knowledge and education to provide with them the information they need to know that that's maybe not the best direction to go. So really any conversation where the patient doesn't want to listen, they came in, this is what they think they need, and then trying to steer back from that. And the list can be a mile long. Like I said, it was like I was going through all this list and I was like, there's a trend here. And it's when the patient thinks they know already what they need and then how to steer that back.
Yeah, there's a downside to all that knowledge we have access to online, isn't there? Mark, how about you? What are the most challenging types of conversations you have?
Well, Sarah hit them on the head because those are the ones you find. I couldn't say it better, and that's usually a common theme is they just want to tell you what they need, and you're supposed to listen to them despite everything else. And I think the other part about it is it goes back to that first comment, just getting the, finding out what the patient's thinking, what they know, trying to use, objective data back to them to help them along the process, because, that's key, just versus saying, no, that's not appropriate. You have to, bring them up to speed, use what objective data you've collected, and then, work to partner with them in some ways, educate them or show them how there's maybe something else to consider to try and get them to buy into the conversation, because you can just fight them and not get anywhere, or they just give you a bad patient review because they think you didn't do what you wanted. That's a hot topic too. But I think the other subject matter that I run into a lot is hospice, just because of my practice has more of that now than maybe I had in the family practice clinic. But I think hospice in general, that's a good conversation to get skilled on, and to think about even in the internal medicine or the family practice clinic. I think too often those kind of difficult discussions are pushed off until late in the process. And so I find that that's another angle of trying to educate them about what palliative and hospice care is, versus, I'm not giving up on you, or I'm not giving up on your family member, but to kind of show them also that angle or that approach about living their life to the fullest for whatever's left, in their lifetime, which, we don't have a crystal ball and know, but I think that's another difficult conversation that I run into a lot, besides the prescriptions. The request usually for prescriptions is probably the biggest thing, but hospice is another good area for new people, getting into practice to be thinking about, because using hospice, for example, in the last 24 or 48 hours of life, I think is just really not an effective use of hospice. And a lot of times that's what sometimes not even the patients, but the family members want. They don't want to go there when even the patient may be willing to go there. So that's another difficult conversation. Maybe we'll be intertwined through this conversation today. So I'll stop there.
Yeah, and that's a really, I want to hear more about that, Mark. But both of you brought up prescriptions, so maybe if we start with that, we'll talk about some specific situations. But yeah, the hospice conversations, can imagine those are very difficult, and especially when you're new to practice, just learning how to have those conversations about end of life, terminal diagnosis. Okay, so let's come back to that, but let's go back to, since you both brought up prescriptions. So how, Mark, how do you handle it when a patient asks for a prescription that you don't feel is appropriate for them?
I think specifically, I think you have to get it back to their understanding of why they're requesting that, and what they hope to accomplish. And so I think hearing them out and listening to them can sometimes, I think it's a good way. It's a good approach. Not that you're agreeing with them, but to find out why they think that they need an antibiotic when this looks very, like a cold, a virus. And I think we've seen in COVID a lot, people have been put on antibiotics that really didn't help because they have a viral pneumonia. And, so I think talking about the most likely cause and trying to, teach them in a nice way about like the differences, and then bringing them along in that process with the idea that, potentially I could cause you more harm if I was to, follow your advice based on what I'm seeing. And again, using that objective data to kind of try and support the position you have. I mean, you can certainly sit in the chair of like, well, I went to school and I have the degree, and therefore, you're not getting that next question, and move on. And you just, you don't really, they may just go somewhere else or try to find, or they'll use that against you. If you just initially resist them, I find, like when I was in the family practice clinic, if they felt resistance, they would throw things like, well, the other provider here, whoever that is, they always give me this, when I get this every year, and I just automatically get a Z-Pak. We'll pick on Z-Pak, and so I think it's, again, just about using the data you have, and why, and then, I like to tell them, like, I could actually do you more harm if I was to treat you with an antibiotic, and it isn't going to help your situation right now. And, you could have GI problems for the next year as you recover, et cetera, just trying to help them view it from another angle. So does that feel like I answered that appropriately? Yeah. Like maybe there's other supportive things I can do. What you need right now is a supportive a plan, like hydration, and maybe a cough suppressant at night so you can sleep, but maybe not during the day, because we want you to cough this junk up during the day. I don't want you suppressing your cough, during the day. I want you to use that gift you've been given to cough, be thankful you can cough and get that junk out. So, it's about education, I think, when it comes back down, just partnering and teaching. So that would be my antibiotic or viral approach to things. Sarah, do you want to do something like an opioid, or do you want me to keep going? I'm willing to whatever.
Yeah, I do. I can talk about opioids for sure. So being in internal medicine and being in practice now for 10 years, opioid treatment has changed a lot. When I first started, it was kind of just when we were starting to realize, okay, people with pain don't need to have an opioid all the time. People with pain, there are other things to do besides just mask their symptoms with opioids. And so there still is a culture amongst patients that really feel like they shouldn't have pain, and really that opioids are the best option for them. I think it goes back to kind of what Mark said about antibiotics. It's all about education, really finding out why the patient thinks they need this. Where are they at? What experiences have they had in the past with other things that has brought them to believe that opioids are the only option for them? I believe in really talking about the research that's around opioids and why they're not good for us and why they can make pain worse in the long run. Talking about what other options are there out there for treating chronic pain that aren't opioids, that aren't control, that actually do something rather than just mask the pain here with euphoria. That's all that the opioids are doing, is masking it up here. They're not solving anything within your system. So I think it's really important to really educate patients. And unfortunately, this can take a long time, and it can take multiple conversations, which can be challenging, especially in primary care where we have 20-minute appointments. It's not enough time. And so it's really trying to, again, meet the patient where they're at. If it needs another appointment, invite them to come back. I think being really transparent with them and really telling them, ultimately, if they continue to not kind of heed my advice, being really transparent and say, I don't practice medicine this way. I think this is going to cause you more harm than good, like Mark said. And I think that's okay. If you've done the education, you've, listened to their reasoning, and ultimately the supporting documentation doesn't support, they don't have an MRI that shows a big nerve being pinched or this, that, or the other thing. If there's not a reason to prescribe opioids and they have it set in their mind that that's all they want, you probably aren't going to be able to make them happy in that conversation, no matter what you do. And I think it's okay then to, say, unfortunately, I think we aren't going to agree on this topic. And then maybe helping them find a second opinion, and maybe saying, especially as an advanced practice provider, let me get you set up with one of the physicians here on campus to see, their advice, and if they have any other thoughts for you. And I think you can do that PA or NP to PA or NP, or even, MD to MD. I think that's just nature of the beast. Not everybody's going to make everybody happy. And so I think also having that plan in place and saying, I'm sorry, we didn't agree, but let's get you set up with somebody else to have the conversation again. Does that make sense?
Yeah, for sure. And I can imagine just having that as sort of the backup plan in your head really helps going into those conversations. That there's a little bit less pressure to change the patient's mind, to do what you can to educate. Both of you brought up education, but just to have, pulling in other resources as a backup plan can be really helpful.
I want to add something just briefly. I think sometimes hearing stories or hearing how people can, like sharing a story can help new providers, take that information and use it in a way. I was at a lecture that a neurologist was talking about chronic pain, and had been goes overseas every year, and is involved in, like, they help some really seriously injured people in third world countries, and they don't have pain meds, right? They get something for their procedure, but when they leave without anything for their pain. I mean, they probably get something like acetaminophen or ibuprofen, but there's nothing strong even available, right? And when they see these people back, the people who live there say they come back for follow-up, and they bring them gifts, and they say they don't have chronic pain. And I think the use of opioids sets people up for chronic pain. And so I try to take that story and turn it into, something that, like, that's where the harm is, that your brain actually gets retrained, and your chronic pain will actually get worse over time. And then if you have someone who's been on these meds for a long time, that if they trust you to do a taper and come off of these things, especially when you pick up patients who want their refill and they've never been tapered or something, and you end up in that conversation, I think telling them that they have to trust you, and that the next couple months might not be super comfortable, but if you can get them through, you're not stopping them, but you're coming down on the medicine. But if you can get them through some discomfort, once their body starts working again, because we will make our own morphine and our receptors, we will basically, they will come around to a much less painful life. And the neurologist has a benefit of this patient that he uses as an advocate, that he was actually able to, this was just an example of one, but he was able to get this person to trust him, get through this, and now goes around as an advocate for other patients to say, this really works. And so I use that a lot in my own, even though that's not my patient, but that experience of telling the patients to trust you, that the body will do things. And then, if it is something, physical therapy is right around the corner in most of our clinics, and they're awesome. And people, there's other things that, so it's not like you're saying, nope, you don't get the medicine, but here's what, here's another thing, that we can use to help you get better. And so I don't know, I think just if that experience helps people frame up some kind of a conversation about trust and time. And it's not easy, but these medicines were really designed for an acute injury, so a surgical, an accident, an acute time frame. And after that, our body really does a better job. So I like to share that one with, like, when I precept students, just because I think it helps with a difficult conversation.
Yeah, thanks, Mark. And it's such a big topic of conversation over the last several years, and sounds like a very common one. So it could be very helpful for our audience. So I know, Mark, we'll get to the hospice conversation, but I have one more question before that, and I think, Sarah, I'll start with you. Just thinking about, there's a lot of often a lot of conversation needed with patients about behavior change and things that can help them with their health. So, Sarah, how do you handle those kinds of conversations?
I think behavior change is probably one of the hardest conversations to have. It's kind of like trying to change a culture, right? It's the way someone's been living their life, and oftentimes for years and years and years. I think the biggest tool that we have is, again, going back to education, trying to meet the patients where their knowledge ends and trying to then expand on that knowledge. It takes a lot of time. It takes a lot of, there's like a bird flying against my window. Sorry, I just got totally distracted. So it takes a lot of time. And again, that's something that we oftentimes don't have in primary care. So if I have a patient that really is driven to make a change to their behavior and really wants to learn more, I oftentimes will schedule an appointment that's longer. So normally our appointments are 20 minutes. I'll schedule more time so that we can really sit down and try to come up with a plan to really sit down. And let's say we're talking about weight. That seems to be a big one lately. Everybody's, putting on a lot of weight with COVID. And so really sitting down and talking about why we need to work on our weight and the different tools that we have that we can use. So talking about exercise, talking about how diet really is like 90% of weight loss. And so you can work out a lot, but it's not going to be helpful if you don't diet. So then a lot of patients I find don't realize that, carbs are sugar. And so really then educating why, yes, we might not be eating sweets and cookies and things like that, but your potato chips, your breads, your pastas. And so it goes back to the education and really taking the time to sit down, go through all of the reasoning behind it, and then providing the patient with as many tools as you can to help them be successful. I think the other really, really important thing when it comes to behavior change with patients is follow-up. If you have the conversation once and send them on their way, they're probably not going to be successful. They've done tons of research around, for instance, smoking. It might be the 100th person, if you think they're coming into the doctor every few years, maybe not 100, but maybe the 20th person that tells them, you need to quit smoking. Are you interested in quitting smoking? Can I help you with quitting smoking? And sometimes it's just the way someone words it, or the way the kind of wore them down by just continuing to ask them that same the same question over and over again, eventually will help them get to that point in their life where they feel like they can make a behavior change. Another really interesting tool that I've used more recently to help with behavior changes, especially around things like immunizations, is I went to a conference that talked about our wording and how we present things to patients. So rather than saying, you're due for your flu shot today, do you want to get a flu shot? More so, it's flu season. We're starting to see the flu already this year. Would you like to get your vaccination taken care of today? So making it more of like presuming that they're going to get it and let's take care of it today, rather than asking them, would you like a flu shot? Because it's easier to say no to that than it is to say no to the other question. And they've done research again around that. And I have found it just anecdotally to be much more successful. So how you word things can really make a difference as well.
Great. That's a great point, Sarah. Mark, how about you? How do you handle behavior change conversations?
Well, Sarah, it's good to hear another colleague talking to. I like listening to that. It's great, and it's a reminder. For me too, I think with behavior changes, they're hard because we are creatures of habit, right? And so I think goal setting is a great option for your patients. I think not you setting their goal, but asking them what their goal is, and framing it around that where we are today, we didn't just get there yesterday, and anything we do today isn't going to fix it most likely tomorrow. And so kind of saying, we take steps and we have a plan. So goal setting, and then making sure it's realistic. I think a common conversation I have is like, where do you see yourself in 5 years, and how are you going to get there? Not what are you going to do this week or next week, but how do you get to that goal? And what's a long range goal for you? And then you can work on getting there. I think that the patient identifying their goal is key, and then making it realistic. We can help them make it realistic. So, I think we're still talking about SMART goals, that they're specific in their time, they're measurable, so you can see, what's a reasonable goal. And you're going to have ups and downs, and you're going to have good days and bad days, but you always want to keep a positive attitude. So I think it's probably the hardest thing to do is to change behaviors. The easy thing is give me a pill. That's what can't you just give me a pill for that? And it's about the patient being motivated. So how can we motivate them with whatever information we can provide for them? I think it's like smoking. I think 99% of the smokers know that smoking's not good for them, but they still smoke, right? So they know it's not good. And, they say, boy, I wish I could quit, and then, you need them on board. If they just say, I love to smoke, it's like, okay, you know, let's go. No, I'm not saying you give up on them there, but you know what I'm saying? So it's about trying to get them to embrace a plan and then carry that forward. I like the idea of follow-up. I mean, we do it all the time. I change a medication. I'm going to see you in 2 weeks or 4 weeks because I want to see if this made a difference. Well, the same thing should kind of be thought about behavior changes. You know, we should, you know, hold them up for that same thing. You know, well, let's follow up in a month and see where you're at and how you've done. And I like to use the exercise conversation like this because I think this is helpful. People say, well, I can't exercise. You know, I'm not going to run a marathon. I can barely, you know, get up the stairs. It's like, perfect. You know, we're going to set exercise is not I don't want you to be negative about it. I want you to think about the positive. You will feel good. What is exercise? Well, could you, for instance, I like to say, find something you can do every day. So if they say, well, I like to walk to my mailbox and back. Well, fine. Can you do that in December, January, and February around northern Minnesota or Wisconsin, right? Or northeastern, right? So, you know, that's fine. But then we need to have a plan for when there's other things that keep you from doing that exercise, whatever it is. And like I love telling retired people, well, you used to work 40 hours a week, right? I'm not going to ask you to exercise 40 hours a week, but how about 20 minutes a day? You know, and could you walk 10 minutes as fast as you can tolerate and then turn around and walk 10 minutes back? And they go, you know, that's something that they can, oh, so if I do that, you know, and you start small and then, you know, from there they can grow. So I don't know, I throw those out as examples that maybe you know, for the people listening, when they're in practice, they could steal it, you know, take it, use it, run with it, make it your own, adapt it, but set goals, realistic, and hold them accountable. And you know, in a good way, not a bad way, not punitive, but
Right.
you know, encouraging.
Listening to both of you talk. Sorry, Sarah, go ahead.
I just say I love the advice about you used to work 40 hours a week and now you can do 20 minutes of exercise. Another thing that I tell patients to do too is substitute behaviors. So let's say you were smoking at your lunch break, or you would take breaks so you could smoke. Well, maybe go walk instead, you know, do a 10-minute speed walk rather than have that cigarette. So that was another thing that sometimes people can really latch onto, is swapping out behaviors.
Yeah.
Of just not doing something, replace that with something else. Just listening to the two of you talk, it just strikes me how much you're like coaches in some sense. You know, it's not just providing medical care or providing information, but it's doing it the right way. I mean, Sarah, you talked about, you know, asking questions the right way, and you both talked about, you know, keeping the big picture in mind, but having, you know, smaller, doable steps to get there. Yeah, there's a whole lot to this. That's more than just providing medical information and moving on.
Yeah, I'm going to say, I'll just add too, I think that it's really easy just to give information and state this and be that way about it, but that I don't think is as effective. So.
For sure. All right. Mark, so you brought up the hospice conversation, and so my question for you would be, how do you talk to patients and family members about progressing dementia or a terminal diagnosis or possibility of moving into hospice? How do you handle those conversations?
Sure. Well, I think the thing about memory and dementia, whether it's advanced or advancing, I think it's about just having that conversation. I think having a more of like a triad type of a conversation. So for instance, if it's a patient with some cognitive decline that's maybe it's fairly severe, but you know, I think a lot of times families and family members protect the loved one from memory issues, right? So you have things that are probably progressed more than people really want to admit to. So I think having that conversation with the family member and the patient together, and you as the provider, and being, you know, maybe a good opening line is just to ask the patient, well, wait, I'm gonna back up. I think setting some ground rules are really important. So the number one thing is that the patient gets to interrupt and be the person that talks, and the family members get their time to talk, but they can't interrupt. Does that make sense? So the patient can interrupt, but it can't be the family member interrupting the patient. And I think talking to everybody involved, um, so there's no hidden sideline conversations, are really important. And granted, I think an opening question, just like to the patient, is, have you noticed, how do you feel your memory is? And people will say it's not as good as they'll tell me all the time, well, it's not as good as it used to be. I have really good days, and then usually someone will spout in, oh yeah, there's more bad days than good days, or whatever, or they all want to interrupt us, like, no, they're talking right now. So so when when you get that kind of confession and sort that things aren't as good as they used to be, it kind of helps, that that discussion that nobody wants to hold about memory, and then, from there, I guess I just think about, um, really talking, and being really clear to the patient, speaking to the patient and getting the patient. And certainly there may be instances where they are nonsensical and they can't really follow you, and it's a little bit more clear to the rest of the family. Other times they may carry on, but and do pretty well in certain areas. But it's kind of about normalizing that there is this pathway that is along the process, and sometimes even more advanced than one thinks. I mean, I can tell you of numerous patients who are pretty advanced dementia, and family still thinks they're fine because they know them, but they can't put everything else together. So I think having that triad type of meeting, setting ground rules, just being, getting things to the surface and talking about it, are really, really important. And then, certainly medications are an option, and just being really forthright about the efficacy of them and how well they do or really don't work. And, I think you always try things if the patient and or the family want to try something that's not going to cause harm, for a memory drug. You set it up with, they're amazing, they're approved because they don't have a whole lot of great efficacy, but let's try it, and as long as we don't make things worse, we can always stop it. So sometimes I think people get put on something and it really doesn't help, and then it never goes away, but it's like they really need to take that because it's not going to help them anymore. But so being honest about, like, we're going to do this, we're going to try it, we're going to look for this. If we don't see improvement, we're just going to get rid of it because it's probably not going to help. And then making sure that um, they're not driving still, and those are hard conversations. But when the patient can't drive, the patient can't drive, and a lot of times they know it. I had one the other day. He taught driver's ed, and he's like, I know I should sell my car. I told my students forever they shouldn't, don't let your grandparents drive, or whatever, parent, grandparent. And so he's made the decision. He's going to give the keys to his family and have them either keep the car or sell it. But I mean, just bringing it out and being honest about it really, really helps. I think, again, if we just talk about hospice for along the same line, I think it's just talking about what hospice offers and what it doesn't offer. We're not giving up on your loved one. We're not giving up on you as the patient. I find that the patients often are okay with going to hospice, but family members are sometimes resistant to it. They think that you're not going to do anything more for them. And it's like, once you take the time to explain, like, if they end up sick, or they need fluids, or they need antibiotics, or they need to go to the hospital for something emergent, we're still going to treat that and do that. Just it's just that we can move that along the process. And if it's really comfort focused, and then we obviously aren't. But I mean, knowing that we're not just giving up on them, I think is really helpful. And what the program offers: more support, I'm rambling a little bit, but I'm thinking about like what I try to tell the family members is, you know, the loved one's going to have a nurse who's coming in more regularly. They're going to have caregivers who can come in and help clean them and bathe them and moisturize your skin and talk with them and touch them. And that contact is really good for people. And so this is just going to mean more support. So it's all about giving that patient more support and comfort.
Thanks, Mark. Sarah, how about you? How do you handle those conversations about really difficult diagnoses or end of life?
Yeah, I think Mark killed it. You like hit the nail on the head with a lot of that. So I'm going to kind of reiterate a couple thoughts that I made note of. Driving conversation is a super, super hard conversation. I think I work with a really great physician, and I think more patients have fired her because she's taken away their license than anything else, because it's a really, really hard conversation to have. So a couple tips and tools as far as that conversation goes. Sometimes if you turn it back around as far as telling the patient, how would you feel if something were to happen? If you were to get in a car accident, if you were to hurt somebody or kill somebody, how would you feel about that? Sometimes that can be a helpful part of the conversation. We also have the tool through our therapy department to have a driving eval. And so if they're really adamant that no, they still think they can drive, and then especially if you have a family member that still feels like they can drive, doing that driver's eval can be super helpful to solidify the fact that actually, no, I'm not safe driving at this point. The other couple notes that I made is I tend to ask a lot of questions when I have, especially families coming in together, having that three-way conversation that Mark talked about, and really trying to get a really good idea of where they are at, where their minds are at, whether they're interested in hospice, whether they've never even thought about hospice, whether they think dementia is an option as a diagnosis, or they haven't even thought about that yet. They just thought, that they were getting old and their memory was getting a little bit off. So really trying to find where they're at as a family first can be really, really helpful, because I think sometimes if we have the conversation not too early, because oftentimes we're having the conversation because the diagnosis is there, but if we push the conversation too much right up front, you can do more harm than good. So I think sometimes asking a lot of questions, opening the door, and then maybe providing some resources to take home and look at and read about, and then schedule follow-up. So they can go home, they can process some of the information that was given. We can come back and then have a more meaningful conversation as a group. There's a lot of great resources out there that have different checklists and symptoms to look at that can help support diagnosis. There's great information about the different hospice homes in the area that you can provide and then have them come back around. So I find that to be really helpful too.
And I Sarah, you made me think too, and I want to just correct me if I'm wrong, but just to help the people getting new, if they don't have experiences, usually it's an OT person that does that driver eval, right? So it's an OT referral.
I think we have at Essentia, we just have like an appointment with drivers, it's just a referral. I don't know who does it. But
yeah, I think they're occupational therapists is what I recall, even at Essentia. So it's not real. I think it's just a fine point. I thought maybe that would confirm it, because you're right. You can just go to the ask. It never hurts to ask. And then COG screenings too. The MOCA. MOCA can be very difficult, but like a mini scale, mini mental scale is probably a little bit easier. Some people do really well with certain tests. So I think having a couple of things, Allen's is another test, ACL, I think it's called an ACL test, and that can show if they need more care. So using your, and that's usually occupational therapy too, that does those screenings. So using those to help support rationale for why you might be recommending this. As you were talking, Sarah, I just want to think about too, like movement disorders. Like a lot of people will say, they've got Parkinson's, dementia, and you'll find out that nobody ever diagnosed them with Parkinson's. So it's like looking for those movement disorders that maybe actually happened before the memory and nobody really addressed that pill rolling or that gait issue or that masked face look, and they were just diagnosed with a dementia. And so if you say, boy, when did your loved one get diagnosed with Parkinson's? And they say they don't have Parkinson's, then you know that nobody just really made that diagnosis clear, because that's going to come before the dementia piece. But yeah, I think all those additional things were really helpful. I just wanted to kind of toss us a couple extra points. There's a lot of resources around it to help with supporting evidence.
And there are patients that are really good at faking the test. There are patients that will go online and learn the questions to the mini mental, they'll learn the questions to the MOCA. And so doing further testing, if your facility has like a neuropsych department, can be super helpful. And one way to kind of frame that is, especially if the patient doesn't think there's a problem, is we're just looking for a baseline, let's just go. Let's get their opinion. Let's get a baseline down. So then if we do see progression of anything, we have something to come back to and compare to. So I think that can be super, super helpful, especially for those patients or families that aren't quite there yet.
A couple times when both of you were just talking, I heard obviously pulling in other specialties to support and give more information, but then also just the like Sarah, you mentioned, we got 20 minutes to have this conversation. And so the importance of scheduling follow-ups and making it more of a, stepwise process, because these are such huge conversations and there is so much to process. So just the importance of having that mindset that, I don't have to solve all of this for my patient in the next 20 minutes, but we can get started and keep working together as we continue to meet.
Yeah, and Shannon, with regards to keeping the patient centered too is so important. It's the patient that ultimately is this key component to it. And so often, you'll have family members trying to call you to tell you things about what's going on, and then the patient themselves will get angry. Oh, you've been talking to my daughter, she's always telling so then they get pitted, even if they have the right to tell you that information. But do you know what I'm saying? So I think when you're all in the same room and you plan ahead, if like you said, if you can't, this isn't the conversation that's probably going to go well if they're not all in the same room at the same time. But I just like setting those rules and doing that. I thought of one other thing, if I can add to, don't be afraid to ask if you ever hear, the patient, do you ever hear things or see things that nobody else in the room hears or sees? Because you'll be surprised by their answer. They'll say, all the time. You mean like all these snakes in the room you don't see? Everybody tells me they don't see them. You see them, right? Or they see little children a lot of times jumping on the bed. They'll see little kids in their rooms a lot of time, and they're wondering, they're real to them. So I think asking that question, do you ever hear things or see things that people tell you aren't there, is another good question not to forget about when you're talking to the patient.
Sarah, we've heard family members come up a lot the last several minutes. So how do you handle it when family members' emotions start to run high when they are in the room and you're having these kind of discussions?
I think the biggest thing for me is acknowledging the emotions that they have. I think sometimes if we try to just keep going and push past the emotions, that can be really hard. I think trying to, again, going back to asking questions and saying, I see that this has really upset you. Can you tell me more? Is there more questions that you have that would help you better understand? I think being empathetic, if someone is sad or crying, and showing some, empathy for that is a good thing to do. I think sometimes we're taught to kind of try to remove ourselves from that situation. And I think that can be harder if we don't appear to be empathetic with them. I mean, oftentimes I'll put my hand on someone's knee if they're crying and upset, making sure that they have tissues if they're crying and upset. I think those things are really important. But ultimately, especially if it's anger, I think anger can be one of the hardest emotions to deal with, especially if they start really yelling. It doesn't happen often, but every once in a while, people will really start to yell and become belligerent. And there's been times when I've had to say, I'm really sorry you feel this way. I can see you're really upset. I'm going to step out and give you a few minutes. And I have, and you can, remove yourself from the situation, step out of the room, give them 5-10 minutes and then come back. And oftentimes that's enough time for them to kind of reflect, calm down a little bit. And then again, you can have that meaningful conversation and going back into the room and being like, you were really, really upset. I'm sorry that I stepped out, but I felt we needed to take that time. Can you help explain to me what's making you feel this way so we can address it? So that's a short answer to kind of a really hard situation.
Yeah. Thanks, Sarah. Mark, what about you? How do you handle it when emotions are running high with family members?
Well, I think my phone conversations, especially over the last year, my conversations over the last year, I should say, have been phone related because of COVID, right? So much has been either televisits or conversations with family who can't get into a facility, a rehab unit, or to an assisted living. So phone conversations can sometimes get, people can get angry because they want something done, or they, so I think the best thing you can do, is, don't avoid difficult conversations. But then if someone's angry and their emotions are running high, I like to listen to them, let them say their piece. And when they're done, reiterate or reframe. So what I hear you saying is this, right? And if they're interrupting you, then you just say, no, I didn't interrupt you. So I'd like you to at least listen to me until I want to have a conversation, but we can't talk over each other. And I've had some doozies, and, they get, they want something and they want their way, but I just feel like you can't back down. But if you listen to them, a lot of, I think, like the empathy Sarah talks about, I think is a lot of it is listening. And if you're in the same room, paying attention to them and not being distracted is so huge. But you can go a long way with that. So I guess that would be my addition. I don't know, I just make sure that they will listen to you too and have that conversation, not a, and it's hard when emotions are high. So
Yeah.
Definitely don't raise your emotions to their level. If they're yelling and screaming and getting upset, try not to raise your voice. If they're standing up, stay seated. Don't ever try to stand above them. And then also another thing to really think about is making sure that you're safe, and so if these conversations are getting really heated, making sure that you still feel safe and don't put the patient between you and the door if you can help it. If you have a patient that's coming in that, let's say it's an opioid patient who wants more medications, or they failed their opioid agreement and you're going to have to stop them, and they've been, maybe a little bit more forceful in the past, get security up there, make sure somebody's standing outside the door. Make sure, if you've been in there and you've been in there for a really long time, that someone's checking on you. I've had times where my nurses have come into rooms and because people have gotten loud and angry about, getting taken off their opioids because they had something in their urine, you know what I mean? And so I think being really smart about it too, to make sure you're safe, is also another important key to keep in mind.
Yeah, that is a really important point. Just going on a little bit different angle with family members, Mark, what happens? How do you handle it when family members request information that you can't share with them?
Yeah, well, HIPAA could be my friend then. I think knowing that, like I do get requests for phone calls back to family members that want more information. And so I use my resources within the office of people who know that stuff better than I, because I don't really want to spend a whole lot of brain power on it, but I do know enough brain power to check and make sure that it's listed in the chart if that is a contact that I can talk to. If I can't, then I don't, and then I either go through the contact that can be spoken to and tell them, that I have a request, and you can certainly, it's your sibling or it's a relative of yours, and the patient as well, hey, your son is asking for information. Do you want me to share anything? And so, and then just making sure all that's documented if there's a request. But otherwise, simply, if they're not approved, they're not approved, and you just there's just no wiggle room on it. So, that's, I find that, helpful, that I can just use that as like patients have privacy. And I'll use my nurse to call the person back and just say, you're not listed. We'll contact the patient and, et cetera, and try to work it out that way. So that's that one for me is kind of an easy one. I don't know, Sarah, what do you think?
Yeah, it gets a little bit stickier, I think, in a couple instances that I think about right off the bat is we see a lot of families. And so I have patients who I treat the kids, I treat the adult, parents, and then the grandparents. And so oftentimes we'll have them in the office, let's say the adult child of the grandparent asking questions about their mom or their dad. And I can't easily then pull up, the patient's chart to see, do they have permission to talk about the patient? And so oftentimes what I do in those situations is I say, I can't confirm or deny anything about any patient that I see because of HIPAA, but do you have any general questions to where I can help answer? So, do you have a question about diabetes that we can talk generally about that? And so kind of speaking hypothetical about their loved ones, if they have specific questions, that can be helpful at times too.
Makes a lot of sense. Let's switch gears now to colleagues. Speaking of sticky, so Sarah, what are some of the common types of challenging conversations you have with colleagues, and how do you approach those kinds of conversations?
Yeah, so this is an endless question for me, really. So just a little bit of background, my section chair role at my clinic basically means I'm the head provider for both the physicians and APs at my clinic. So I'm kind of the admin representative to the clinicians, but also the clinicians representative to admin. So I oftentimes have to have hard conversations with my colleagues. Most commonly, it's around practices and policies. For instance, they're prescribing opioids and they really should be on a chronic pain contract and they're not following kind of those policy rules. So I have a lot of those conversations, and with that, I find it's really important to make sure that you have the supporting documentation. So have the policy, have the information at hand that you can then share with the other providers. I have a lot of conversations around being kind and thoughtful of your other colleagues, and specifically surrounding documentation. So we have some providers that don't like to get their notes done, and really having the conversations to say, we need these notes done so that when your partners are seeing your patients, they can provide the best care possible. Because if your note's not done from 2 weeks ago and it's a follow-up, it makes it extremely difficult. Same goes true for, phone call messages and kind of the MyChart messages. It's making sure people stay up on those, because it can be really hard for providers to do that, and explaining why it's important to keep up on it so your other providers in the clinic aren't getting dumped on when they're trying to cover for that specific provider when they're gone. So those are really hard conversations to have. I think where it gets even stickier yet is when we're getting complaints from patients. So anytime a complaint comes in from a patient, for any of the providers at my clinic, I have to follow up on those and have those conversations. And for that, it's really getting the provider's side of the story. And honestly, most of the time, it's just a misunderstanding, or, the patient perceived something that wasn't correct. And so most of the time, those are pretty easy conversations to have and pretty easy to clean up. But there are times that, providers make mistakes, and everybody's human. And so really taking it as a learning opportunity and trying to then take that kind of uncomfortable conversation and uncomfortable situation and kind of flip it so that it's a learning opportunity for everybody. I think those are probably the most common difficult conversations I have with my colleagues that aren't surrounding patient care.
Thanks, Sarah. I think about, approaching these conversations with grace, but I think about being on the receiving end of those as someone who's, when you've got to talk to a provider about a patient complaint or a concern, there's some grace required when you're receiving that as well, which is really difficult to do. Mark, how about you? What kinds of common conversations do you have with colleagues that are more challenging?
Yeah, I'm thinking about it. I probably, it's, I would say just from work, day-to-day work with counterparts, with other APCs, MDs, I do work closely with a bunch of them, but I don't, I haven't had my biggest thing I think is just keeping emotion out of conversations. If someone's upset with you, some people get really riled up, and to me it's like, well, I think there's just a misunderstanding here, so making sure that you don't get in, it's kind of that their reflection, right? Don't reflect back if they're angry at you, and then find out what you can to understand what's the issue. I have various relationships with my fellow workers, and some of them, I can never do anything right no matter what I try to do. And, I try just to do my work and take care of my patients. So I guess I just say, well, what, I don't communicate enough. What would you like from me? I don't see you every day. I don't interact. So just what do you need? And then I try to learn from that. Just try to be a little bit more responsive. Like, for instance, if they feel like I never ask them questions. So then I try to make sure I'm asking them some questions once in a while so they feel valued. Like I might go to a doc that I work closely or even share a patient with, and I may use that as a resource for a patient care question. And, sometimes I have people calling me for advice, every day. And so I think, well, I'm not doing that back. So maybe I need to do that. So, I just try to change my behaviors in a way that I can, if I feel like that's important. But, I think just trying to understand where there's differences, and making like your teammates, the rest of I call them a team, your whole group of people you're practicing with, feel valued. And so that's kind of the thing that I've found the most of, like, I'll leave it, yeah, without getting specific, I'll leave it at that. That's kind of like just find out where the rub is and what's wrong and how you can maybe, do better, the best you can, communicate better. It always comes back to communication, I find.
Is there anything about just the dynamic, if you're an NP or PA, having a sensitive conversation with an MD, is there anything about the dynamic there that makes it particularly difficult, or that you approach in a slightly different way?
No, I think professionally for both, one of the things that we often see are, as part of our practice, we find out who's in the hospital and who's been called if we're not on call. And so there's a general communication that goes out amongst providers, whether they're hospitalists or internists and stuff like that. And I fall in that internal medicine group. And so sometimes I see snarky comments about something a patient call, and I just address it professionally back in the message. I reply to only that person, and I usually, if I feel it's necessary, I'll copy management, but I just usually keep it between me and the provider if there's something, and just state, you should, you need to make sure you read the chart because the answers are in there. Most of the time, that's more work than people want. So they'll get a little crabby at you, and they'll try to say that, the mid-level, I love that one. The mid-level didn't do this or didn't do that. And it's like, no, actually I did, but you need to, so I think just addressing does that make sense? I do it respectful. I would never put anything in writing that I wouldn't tell them to their face. And I'm always really careful about if I respond to that. And it doesn't happen very often. It's less than once a month, but sometimes you feel like, well, I really got thrown under the bus that time and I didn't deserve it. And, so, if I share that patient with another provider, and usually, it'd be another doctor most often, I'll just talk to the doc about the case and say, hey, here's what I did. I can't help it if the nurse did, in a facility, if the nurse didn't follow what I ordered, but this is what I did. And it's all in the chart. And most of the time it's kind of a eye roll, and it's like, yeah, and people are busy. So the easy answer is just to kind of, you can get blamed for things that really aren't yours. And so I think, sticking up for your, you do a good job every day, and you be thorough, and you document it, and you document it as soon as you can. So, then that way you have everything you need, and it's not as much of an issue. But being respectful, I guess I'd say, it doesn't matter what their title is. Still,
it is a good illustration, your example of just how easy it is to zip off a quick zinger in writing rather than, well, when you're talking face to face, it's much easier to really get the whole story. And of course, that's what happened.
Yeah. I have been known to write a reply in an email and purposely not send it, so that I can just go back and look at it later in the day and go, no, that would not have been a good thing to send. And, maybe reframe it, or just, just say, okay, fine, we'll let that one go. So that's kind of my approach. I don't know. I think communicating is so key for everything we do. And our documentation is our communication in a lot of ways. So like what Sarah said, not closing your charts for getting into practice, just, it's never easier than to write that note, like almost immediately after your visit, or darn close. Someone told me once, try to never have more than 2 to 3 open charts. So if you're going into your 4th patient, before you go see that patient, take care of those other ones. Take 5 minutes, because it'll take an hour later. So
Sarah,
one tip,
go ahead.
I was gonna say, one tip that I have, because I will say that when I have difficult conversations on the admin side of my job, it doesn't matter to me if it's an AP or an MD, but I will say sometimes when I want to have a conversation, especially if it's a conversation about how somebody's practicing medicine, that can be more challenging when it's an MD to me as an AP. And so one technique that I've used in the past that I've found helpful, especially if I know it's going to be with a physician that maybe is going to put their, kind of be more defensive or kind of be a little bit more confrontational with me, is I try to go into it presenting it as a learning opportunity for me, asking more the question of, I saw this patient of yours and I was looking back and I saw that you did this, and can you explain to me your thought process on kind of what you were thinking and why you went the direction that you did? And I find sometimes that can really then open the conversation and say, I want to learn more about why you did it this way. And then once the conversation is open, you can have that dialogue back and forth very respectfully, if they're not on the defensive right away. And so oftentimes, I'm learning something and maybe they're learning something too. I've been in practice 10 years, and I will say that those conversations, when I'm really worried about the physician getting defensive, is much less than it was back when I started 10 years ago. For the most part now, most of the providers and physicians, especially that we work with, are great, are used to having PAs and NPs that are very immersed in their practice, and it really is collaborative. But you still come across those physicians that are gonna, say you're only a PA or an NP, or like Mark said, a mid-level, which don't ever say that. You still have those providers out there. And so kill them with kindness, really make sure you have your ducks in a row before you make that phone call or before you go down to their office. Make sure you have the information you need so that you're not getting asked questions that you don't have the answer to. So those are kind of my tips, because those can still be tough conversations at times.
Kill them with kindness. Love that.
Yeah, I think too, I don't know how it is for you, Sarah, but for me in my practice, I always copy my, if I'm not the primary and I see someone, I copy the note back to the provider, to the primary doctor or whoever that is. And I always, in my statement up front, I say, this is primarily a patient of, Sarah Carl, PAC, and then I copy them on that note. And, in your plan, you have a plan so they can follow it. If they read it, they got to read it. But if you, as long as you put it in there, and I think that, is good too. And I take time to, when I see like a provider who will even, like, I know physician extender, so that's even older than that. I purposely, like, hey, I saw your patient the other day, and then I get into a conversation and here's what I did. And, it's actually works to build those relationships. So there really isn't as much friction within the clinic or within the relationship. So that's my additional two thoughts I had while you were talking there.
Yeah, and I imagine the more you work with these people and just develop relationships, and they know you're coming from a good place rather than, a place to put them in defensive mode. That makes a big difference too. All right, well, my last question for you, Sarah, I think we'll start with you for this one, if that's okay with you, is kind of the wrap-up question. So if you had to give one piece of advice to new advanced practice graduates about having difficult conversations, what would that be?
I think we've talked about a lot of different things. And so the one thing that I feel like we haven't touched a ton on that I'm going to leave as my last piece of advice is don't avoid the conversation. Don't put it off. Don't keep saying, oh, I'm going to do it tomorrow. It's important to plan. Like we've talked about planning right away off the bat. It's important to have your ducks in a row, but don't keep putting it off, because oftentimes you're going to make it to be more of a thing than it's actually going to be. I mean, most of the time we get so worked up about these tough conversations, and 95% of the time it goes so much better than you think it's going to go. So don't put it off. Just go for it. You'll be fine.
Thanks, Sarah. Mark, what about you? What's your one piece?
I hear the dog is saying it's over.
Yeah, we almost made it without a dog. Well, I guess mine
I have
has
my
it.
little piece of paper here, and it says, plan for it. You're going to have them, and don't put them off. Sarah, did you see my paper before? I really think that's it. I think you do things, treat people the way you want to be treated. Don't put it off, because it only makes it worse if you don't address it. I have a couple people in my practice, family members, that I regret. I don't want to make this phone call because I know it's gonna be a half-hour phone call, but I find that if I just do it and I get it over with, everybody's happier. And the patients, a lot of times patients' families, for me, their family is happier. I just don't let them abuse me, and I don't let them constantly, you shouldn't be a punching bag, but when you have a difficult conversation, that's well said. Just don't put it off, and you sleep better. I think our minds are really great at all the worst case scenarios. We'll have 8 of them going, and they won't be even accurate. So just don't be afraid of it, and that's great advice. So that's what I agree.
Sounds like it's unanimous.
Yeah.
Plan, do your homework, and don't put it off.
Yeah.
Well, thanks. This has been wonderful. I just so appreciate both of you taking your time to share your experience and your advice with us. These kinds of conversations aren't easy for any of us, providers or not providers. And when you bring in, working with patients and working with families, it just adds that much more layer of complexity to things. So it's just really helpful to hear from you, so we can learn from your experience. So I really appreciate your time, appreciate your expertise, and appreciate you, both of you, serving as preceptors in this program. It's such a valuable, you bring so much value to education of our advanced practice students. And thanks, I'm going to just thank all of you who are watching this webinar. We encourage you to check out the other webinars in this series so that you can continue to add more tools to your toolbox, just to help you smooth that kind of choppy, challenging transition to practice. We're really glad you joined us, and we wish you a very enjoyable day. Thanks, everybody.